me in Oliver, and it happened that I was so sick to the extent that I couldn't even move my whole body. I experienced a very thick headache, and if I try to stand up, I feel like falling, and I felt very dizzy. So to the point that several tests was conducted on me, and coupled with the fact that that month my monthly flow came, and I was so confused. I felt very down. I thought I would die. I felt very scared though. So the doctor tested me, and I was admitted at the hospital. So he said that I needed blood, that my blood was very low. So they started looking for donors, and thanks to God, and the blood saved my life. Donate blood and save life.
What to look out for when your patient is about to be transfused with blood. Ensure the pint of blood is certified. All certified units of blood have been tested and have been found to be free of all transfusion transmissible infections. To know if the blood is certified, confirm there is a certification label attached to it. Also ensure you can see the logo of the Lagos State government on it. The same is applicable to other blood components, including the fresh frozen plasma and the platelet concentrate. This information is brought to you by the Lagos State Blood Transfusion Services.
What prompted me to start donating blood was because of a collapsed building at Itafaji, I think 3 years back. And getting to the hospital, they said the victims needed blood and there was no enough blood in the blood bank. So that was what motivated me to start donating blood. I donate 4 times every year. I've been donating since 2019. I will encourage them to start donating blood that it doesn't kill. The more you donate blood, the more another blood flows in and you'll be healthy and fine. Donate blood, save lives.
A prize so priceless, a gift so expensive it only flows from the heart. Blood, the gift of life, when given, gives the giver a new glow, new cells to renew the functionality of tissues, organs, and systems. Givers of this gift always known to be fit. Donors, the true heroes in this feat. Excess iron given off and their livers revitalized. Immune system improved, risk of cancer reduced. Possibilities of heart attacks lowered and new blood cells produced. A gift when given that blesses the giver's life. Wouldn't you rather be one? Donate today, save a life, and that life might just be yours.
Orúkọ mi ni Abdulganiu Adéyẹmí Dòsùnmù. Mo wá láti ìpínlẹ̀ Èkó. Tí bá máa rántí on the 10th January 2011, ìjọ yẹn ìyàwó ẹ̀gbọ́n mi fẹ́ bímọ, wọ́n dẹ̀ fẹ́ ṣe operation fún. Wọ́n fẹ́ ṣe operation fún, tí wọ́n wá lọ nídìí láti gba ẹ̀jẹ̀ yẹn padà. Ní inú ibi báyìí ẹ̀mẹ́rin àǹfààní tó dá wà ń bẹ, ó ń jẹ́ kára jí pépé, kò ní sí àìsàn kankan lára, èèyàn máa wà alright. Wọ́n máa bẹ̀rù àǹfààní tó dá wà ń bẹ because lẹ́nu ọjọ́ mẹ́ta yìí náà tí ìyàwó tèmi náà fẹ́ bímọ, mo jàǹfààní pé mò ń fi ẹ̀jẹ̀ sílẹ̀ déédéé, nínú mi dẹ̀ dùn sí, tó dẹ̀ fún mi ní ìwúrí àti tí máa ṣe sí tí máa fi dàgbà. Ẹ̀jẹ̀ fífílẹ̀ dá o, ẹ lọ́ máa fẹ̀jẹ̀ lẹ̀ o, ó ṣara láǹfààní kẹ́dẹ̀ fi máa ṣèbò ẹ̀mí o.
I donate blood to save life. I've been donating blood since 2010, and right now I donate 4 times in a year. I donate blood to save life, and aside the fact that you are saving lives, it also reduces the risk of having liver and heart diseases. It also reduces the risk of having cancer disease, and it helps develop new blood cells and so many on. I donated blood because I was invited by a friend then. He actually told me that donating blood saved lives, so I said, okay, let's go together. So that was actually my first reason of donating blood then. They don't need to be scared because each time you donate blood, aside the fact that you are doing yourself good, you're also saving other people's lives. Give blood to save lives.
Blood is donated from the donor clinics of hospitals. In Lagos State, we've got 28 public donor centers, which is resided in the general hospitals, as well as the Lagos State Blood Transfusion Service donor centers. When blood is donated, the blood is taken to any of the 8 screening centers in Lagos State. The blood is screened using a 4th generation ELISA technology to be sure that the blood is free of infectious agents like HIV 1 and 2, hepatitis B, hepatitis C, as well as syphilis. Once it is screened and deemed fit for transfusion, the Lagos State logo is attached to the blood to show and to certify that the blood has been duly screened through quality assured measures. Following the screening process, all the blood is stored at the blood bank waiting for the request for it to be cross-matched for transfusion. Once there is a need for blood from any of the hospitals, the request is taken to the blood bank with a well-filled form as well as blood in a plain bottle for the appropriate cross-matching processes. Blood isn't just given like that. Every unit of blood collected at the Lagos Blood Transfusion Service is appropriately processed into blood components because we want you to know that each unit of blood can save 3 lives.
At times, we have different blood products and blood we requested from which hospital. We can request for whole blood, packed cell. If it is whole blood, this is how the blood looks like. And any blood in Lagos State without this logo, you cannot issue it. And in case the doctor requested for fresh frozen plasma, which is another product, his own logo is different from the logo of the blood. Now, after that, then you proceed on the cross-matching. In the request form, the doctor can indicate if it's an emergency or full cross-match. The emergency takes 15 minutes, while the full cross-match takes 1 hour. And in Lagos State Blood Transfusion Service, all donor, of course, we do more of voluntary blood donors. All units of blood collected from our voluntary donors, our team, right, we are all genotyped. That's why he's running the genotype of the blood now. And the patient from each hospital also requests for genotype to serve blood because of sickle cell patients or some patients who have pathological disorder. Then after the cross-matching with the normal process, we do at room temperature, you incubate at 37 degrees centigrade. After the completion of that, then you proceed to the record section.
So each unit that you donate can save 3 lives. And that's why we appeal to you that you be a lifesaver.
Donate blood, give blood,
Save lives. Save lives.
Continue to give blood, save lives.
found to be free of all transfusion transmissible infections. To know if the blood is certified, confirm there is a certification label attached to it. Also ensure you can see the logo of the Lagos State government on it. The same is applicable to other blood components, including the fresh frozen plasma and the platelet concentrate. This information is brought to you by the Lagos State Blood Transfusion Services.
What prompted me to start donating blood was because of a collapsed building at Itafaji, I think 3 years back. And getting to the hospital, they said the victims needed blood and there was no enough blood in the blood bank. So that was what motivated me to start donating blood. I donate 4 times every year. I've been donating since 2019. I will encourage them to start donating blood. That it doesn't kill. The more you donate blood, the more another blood flows in and you'll be healthy and fine. Donate blood, save lives.
A prize so priceless, a gift so expensive it only flows from the heart. Blood, the gift of life, when given, gives the giver a new glow, new cells to renew the functionality of tissues, organs, and systems. Givers of this gift always known to be fit. Donors, the true heroes in this feat. Excess iron given up and their livers revitalized. Immune system improved, risk of cancer reduced, possibilities of heart attacks lowered, and new blood cells produced. A gift when given that blesses the giver's life. Wouldn't you rather be one? Donate today, save a life, and that life might just be yours.
orúkọ mi
Good morning, everybody.
Good morning, colleagues, medical doctors, medical directors. Good morning, medical lab scientists, technicians. I really do want to welcome everybody, donor organizers, our volunteers, and blood recipients that are on this platform, ready to listen to adverse events in blood transfusion. We have had a lot of webinars in time past, but this webinar came up following a lot of reports on from our vigilance unit about a lot of possible transfusion reactions. And we found out that there are quite some gaps in our practice about identification, about management, and all that you need to do with respect to blood transfusion reactions. At the end of this webinar and workshop, we're hoping, and I believe, that all participants will be able to identify the different types of blood transfusion reactions, the acute ones, chronic ones, or the delayed ones. You'll also be able to know what to do to manage these cases. We'll know the laboratory investigations involved. You know the documentation lines that you need to take part in ensuring that a hemovigilance report is duly made. We hope that at the end of this, the incidence of reporting such will also reduce, especially when it comes to the near misses. I welcome you all once again to the Lagos State Blood Transfusion Service. I welcome you once again to our quarterly webinars. Thank you very much.
In line with our vision and mission, I am Ajibola Oluremi, a medical laboratory scientist with the Lagos State Blood Transfusion. In pursuance of our mission and fulfilling our mandate, we have brought an erudite scholar who will do justice to our topic of today. He is Dr. Ademola Adewoyin. He obtained his medical degree from the College of Medicine, University of Lagos, and completed residency training in hematology and blood transfusion. Dr. Adewoyin holds the postgraduate clinical fellowships of the West African College of Physicians and the National Postgraduate Medical College of Nigeria in hematology and laboratory medicine. His professional training and experiences include visitorship and preceptorships at international centers of excellence, including Duke University Medical Center, NC and MD Anderson Cancer Center, Texas, USA. Dr. Adewoyin has attended several international conferences and trainings, including United States and Canadian Academy of Pathology and International Society of Laboratory Hematology. Dr. Adewoyin has keen interest in healthcare delivery, quality, laboratory quality management system, healthcare leadership, administration, and biomedical research. Currently, a faculty member in the College of Medicine, University of Lagos, and consultant hematologist, Evercare Hospital, Lekki, Lagos. It's promising to have a very educative and informative session. We want you to stay tuned and you'll get the best. Thank you. Dr. Adewoyin, you have the floor. Thank you.
Thank you very much, Ma. I wish to take a kind permission to pull up my slide, and I want to believe the slide is up. Please, can I get a feedback that my slide is up?
Yes, we can see your slide. Thank you very much, Dr. Adewoyin.
Yeah, thank you very much. I want to especially appreciate the initiative behind this. My thanks to the Honorable Commissioner of Health, Lagos State. Again, my thanks to the Executive Secretary, Lagos State Blood Transfusion Service. And thanks to everyone who has been involved in organizing this webinar series. So the topic I have today is to talk on adverse events in blood transfusion. And I think it's important that we take things from first principles. So what I will try to do is to do some definition of terms, blood transfusion, what are blood components, what are blood products, and then we'll look into these adverse reactions or adverse events to blood transfusion. We'll try to categorize them and then look at how they present clinically, and then we'll look at how to manage these transfusion reactions or events, and then the overall outcome or the objective of this talk is actually to improve our blood transfusion outcomes. Now, so what is blood transfusion? It remains a mainstay treatment in many clinical conditions. So it's difficult to practice modern day medicine without transfusion. That is a no-brainer. Now, blood component therapy has to do with trying to meet specific physiologic needs in the patient. And if you look at some of these needs, we're talking about patients who have become anemic and then we need to correct their hemoglobin deficit. We're talking about patients with bleeding entities and then we need to replace the coagulant proteins. We're talking about patients with low levels of their platelet numbers and then we need to optimize them. And so these all warrant some form of transfusion. Now, infusion of these blood components may be hazardous, and these are the things we are looking at today because these hazards essentially will contribute additional morbidities and then can also lead to death, depending on the severity and the type of blood transfusion or adverse event that is being manifested. Now, to be a bit more technical, we can say that transfusion has to do with the therapeutic infusion of blood components, and blood products into an individual in order to meet a specific physiologic need. And then there's a bit of difference between blood components and blood products. Now, blood components are the therapeutic components of blood intended for transfusion. So something like your fresh frozen plasma is a blood component. Something like the packed red cells, they are blood components. These are direct components derived from the whole blood. Now, blood products are a bit different, and these are therapeutic products that are derived from blood or plasma, and they are typically produced through manufacturing process. So these are products that have gone through some processing, some pharmaceutical processing, for them to be useful for transfusion purposes. So we talk about things like the factor concentrates that are derived through fractionation technologies or pharmaceutical processing. Now, just to also spike our interest, that transfusion medicine goes beyond just blood and blood components. It also covers a wide range of other products or other components or therapies that is currently deployed in modern day care. So it covers things like peripheral stem cells, covers recombinant coagulant proteins, it covers the erythrocyte stimulating factors, even IV immunoglobulins. So just to broaden our mind. Now, how do we define adverse events? Now, you can look at it in different ways. If you like, you can say there are morbidities associated with transfusion of allogenic blood and blood components. You could also say there are resultant effects of unsafe transfer of blood from donor to recipient. You can say that these are myriads of complications that are described in association with blood transfusion. They actually burden and potential hazards, associated with blood transfusion. But this appears, I kind of tend to prefer this final definition, which talks about undesirable and unintended response or effect during or after administration of blood components, or blood products that can be associated with a said product. Now, why should we talk about adverse events or adverse reactions to blood transfusion? Now, if there is any reason why we need to talk about this, is because this is a very important measure of care quality. And in terms of the impact on patient outcomes or patient care, adverse events in transfusion will certainly worsen outcomes. It can lead to patient decline. It can trigger additional morbidities. It can lead to death. It can lead to disabilities. Of course, it would heighten the cost of healthcare. It will prolong hospital stay, and then also introduction of iatrogenic infections. And then I borrowed this from the Institute of Medicine in the US. They talk about the 6 elements of quality care, of healthcare quality. And I'm leveraging that in order to also put the essence of this talk into perspective. Now, according to the IOM, they talk about these 6 elements. Safe care, I mean, quality care includes safety of the patient. What's the essence of transfusing a patient? You've been able to raise the patient's hemoglobin level, and at the end of the transfusion, you've been able to infect the patient with hepatitis B. And so that is not a safe care. Now, quality care as regards to transfusion has to be effective. So if the target is that we want to raise this patient's hemoglobin, then the outcome must be that we have been able to raise this patient's hemoglobin or hematocrit from a particular level to a better level. That is effectual care. Now, patient centricity is very important, and that talks about respect of person. It talks about the patient's interest being at the center of whatever care we're giving. So we're not taking decision because of the money or because of the returns we are going to make in the process of transfusion. We're taking the decision because that is what is best in the interest of the patient. It has to be timely. What is the essence of blood products or blood components arriving following an emergency or following a road traffic accident when the patient is already exsanguinated? So if it's not timely, it's not quality. It has to be efficient. How do we run quality transfusion service such that we do not have wastage? How do we ensure that we have lean management of our resources? And of course, it has to be equitable in the sense of distribution of resources, availability of blood products, irrespective of your age, of your gender, of your location. It has to be equitable. And then the summary of this is that what we try to achieve is that there should be nil or negligible adverse events or adverse reactions to blood transfusion. Now, these are some thoughts I think I should share. And the first one is, do patients react to blood transfusion in Lagos? Precisely. How frequently are these adverse reactions? What type of adverse reactions are we observing? How many patients have died from blood transfusion complications? We've all had this sort of encounters. How do we fully investigate transfusion reactions? Are these reactions even reported? Are those reactions avoidable? Are they largely preventable? Are these adverse reactions on the decline or on the increase? Do we have this data? Are we vigilant? Are we hemovigilant? Because I mean, the simple rationale is this: if you can't measure a process or you can't monitor an activity, you actually cannot improve that process or that activity. Now, this is a bit generic. We're looking at the epidemiology of transfusion reactions, and it ranges from as low as 1% or even lower than 1% in developed countries like the US to as high as 8.7% based on literatures are found, and even higher than that. So what we're saying is that approximately 1 in every 10 transfusion will experience some form of adverse events following the transfusion. And these transfusion reactions are numerous, and they are varied in their intensity and their severity. Now, how do we categorize these transfusion reactions? Typically, we would look at them based on the time of onset, and then also we look at the underlying pathophysiologic mechanism. What is the mechanism of evolution or development of these transfusion events? Now, in terms of time of onset, I mean, typically we'll look at them as acute, delayed, or long-term complications. Acute meaning those that occur within 24 hours of transfusion. Now, those that occur in excess of 24 hours of transfusion to about 4 weeks post-transfusion, they are categorized as delayed. And then the long-term ones are the ones that range from months to years, things like iron overload, things like infectious complications of transfusion. Now, in terms of their pathophysiologic mechanisms, they're twofold. We talk about the immune etiology and then the non-immune etiology. Take, for instance, the acute hemolytic transfusion reaction. That is immune in origin. And then take, for instance, something like the loading of iron from chronic transfusion or repeated transfusion of patients that are transfused regularly. That is non-immune. So that is how we sort of categorize, and that pictogram there helps to have a generic view of the categorizations of transfusion events or transfusion reactions. Now, the first one I think we should look at is the febrile non-hemolytic transfusion reaction. This is the commonest acute reaction, and the occurrence of febrile non-hemolytic transfusion reactions, they're commoner with cellular components as compared to plasma components. And the reason is not far-fetched, it's because cellular components like neutrophils in stored blood, they are released over time, and these are pyrogenic in nature. And that is the non-immune etiology of febrile non-hemolytic transfusion reaction. So they are typically more common with cellular products. They are also common with something like the whole blood derived platelet concentrate. compared to the red cell transfusion. So something like the platelets we harvest from cold centrifugation would give a higher chance or pose a higher risk of febrile non-hemolytic transfusion reactions compared to red cell transfusions. Now, multiply transfused persons, multiparous women, they are at a higher risk of febrile non-hemolytic transfusion reactions. And like I said, the etiology is either immune or non-immune. The immune mechanism has to do with being exposed when persons have been sensitized to particular antigens that are foreign to themselves. Once that happens, they develop these antibodies that begin to attack the antigens in the donor blood component. And so that triggers a sort of systemic inflammatory response syndrome, and then that leads to fever, and that's the mechanism in the second mechanism in the febrile non-hemolytic transfusion reactions. And I mean, of course, the implicating antigen and antibodies are usually HLAs for the febrile HLA antigens and antibodies for the febrile non-hemolytic transfusion reaction. Now, what is the clinic of this kind of complication? Now, there is a classic fever that is at least 38 degrees, or a fever of at least 1 degree rise from the baseline. So a patient pre-transfusion has had 38, and then intra-transfusion, the fever rises at least a degree above the baseline. It typically will occur within 30 to 90 minutes of initiation of transfusion. There might be associated chills and rigors and headaches. And then it's important to exclude other causes of transfusion pyrexia. So we need to understand, was this patient pyrexic before the transfusion? What are the morbidities in this patient? Are we standing a risk or any risk of septic transfusion reaction here? Is there some sort of transfusion-related acute? I mean, these are the other differentials of transfusion pyrexia. Now, typically, we know this to be more troublesome than dangerous, just like the allergic reactions as well. Now, in terms of managing febrile non-hemolytic transfusion reactions, in any suspicion, it's important to temporarily discontinue the transfusion. It's important to ensure that there is a good intravenous access, and then you do some hydration with isotonic fluid. And then it's important to institute antipyretic agents. As simple as paracetamol is sufficient. Typically, we avoid things like NSAIDs in any sort of transfusion reaction. And the rationale for that is that there are some transfusion reactions that portend bleed. And by the time you introduce NSAIDs, you are going to worsen the bleeding tendency because of platelet dysfunction or thrombasthenia. Now, for intercurrent allergies, or urticaria, it's important to give antihistamines like chlorpheniramine. In refractory cases, we then would need to introduce glucocorticoids like the hydrocortisone, usually in our transfusion orders. And then once the symptoms are controlled, typically in 30 minutes to 1 hour, we can resume the transfusion at a slower pace and then complete the transfusion for febrile non-hemolytic transfusion reactions. Now, how do we prevent this? It's important to have a good transfusion history. Number two is that sometimes for patients that are at risk of this kind of reactions, we can do some pre-medications. Typically, we do some hydrocortisone and then give paracetamol as pre-medications. And then it's important to pace the transfusion. A slower rate, should be initiated. The transfusion should be initiated at a slower rate once the symptoms abate. And then there is also the option of pre-storage leukodepletion of blood components. Now, there is a protocol, the universal, leukodepletion of cellular blood of blood components. Now, this is a bit tricky, but I know some nations have a protocol on universal leukodepletion of blood components. And now this is what this leukodepletion looks like. If you're able to see my cursor. I mean, there are two pictures or pictograms I've put here, and then this is what the leukodepletion filter looks like, an LD filter. Now, if you have to introduce this in our kind of setting, the cost of blood is going to be high, because the last time I checked, as about 2 years ago, a leukodepletion filter cost 25,000 naira per unit. I'm sure because of the foreign exchange rate, it's going to be higher than that right now. So if you have to do universal leukodepletion for each component of blood, because you're trying to prevent febrile non-hemolytic transfusion reactions, you're going to raise the cost of blood almost to ×2 or ×3 of the current value. The question is, can we afford this? So can we manage the risk of febrile non-hemolytic reactions versus, introducing a protocol on leukodepletion, universal leukodepletion of blood components? Now, the next one I'll talk about is the acute hemolytic transfusion reaction. This is the most dangerous acute transfusion reaction. Now, frequently, this is due to clerical errors. This is related to things like mislabeling of samples, patient misidentifications, erroneous interpretation of tests, and then misrecording or transcriptional errors or other clerical issues that may arise. Now, this is why there is a lot of emphasis on documentation in blood banking. If you have a wrong documentation process, or you don't have a clear protocol on documentation, and then the processes and protocols are not duly followed, we stand the risk of clerical errors, which can be a sentinel event and can lead to a lot of morbidities and mortality. Now, mortality rate in acute hemolytic transition reaction can be as high as 10%, which means that you might lose 1 in every 10 patients, and that is quite significant. Now, how do this happen? Now, typically, the typical setting for acute hemolytic transition reaction is actually the ABO mismatch transfusions. For instance, take a O recipient, a patient who is ORHD positive, and then is a recipient, and then you introduce blood to such an individual from a B donor or from an O donor. Now, these persons that have the ABO, the O blood group antigen system, they're going to have naturally occurring anti-A and anti-B. And by the time you introduce or make such errors, you're going to provoke a massive intravascular hemolysis. And that can be quite catastrophic, and the degree of hemolysis is going to depend on the site of hemolysis, whether it's intravascular, extravascular. ABO mismatch tends to cause intravascular. Things like the RH blood group system tends to provoke things like the extravascular hemolysis. So it's going to depend on the class or the subtype of the implicating antibody. It's going to depend on the volume of blood units that has been infused in the patient. A patient that has received 50 ml of blood is different from a patient that has received 300 ml of blood. The reactions are going to be on different scales. And then the patient's pre-morbid or pre-transfusion state also determines the outcome here. Now, how will this patient present, or how do we pick this kind of reaction? One, some of these patients will complain of pain or sort of heat at the infusion site or at the site of cannulation. There's this feeling of impending doom, there's this feeling of impending doom. Some of them will experience chest tightness. There'll be loin pain because of impact on the kidneys. There would be fever associated with chills and rigors, tachycardia, hypertension, which may progress to shock. This patient would have perennial acute kidney injury, and then that can also progress to ATN, which is intrarenal, and then some of them will progress to develop disseminated intravascular coagulopathy. And by the time you have a DIC setting in, it's becoming a bit more tricky and dicey and requires a lot more support to be able to recover this patient. Now, in the unconscious patients, they might not be able to give or manifest some of these features. And then it requires a higher index of suspicion for those that work in ICU. By the time a patient is on transfusion and you are noticing hypertension, or you're noticing a change in the urine color, a change to some sort of coke coloration or lifting or reddening of the blood or the urinary output, or oozing from the infusion site, this should raise your index of suspicion that you might be dealing with some sort of transfusion adverse event. And then it can also mimic in sickle cell disease, can mimic the hyper hemolytic crisis in sickle cell disease, because they would also present with intravascular hemolysis. Now, how do we manage this patient? There are laboratory investigations that are warranted in order to be able to clinch a diagnosis of acute hemolytic transition reaction. One, it's important to repeat the grouping and then repeat the cross-match. And then it should be performed with the patient pre and the post-transfusion samples. It's very important to have a direct antiglobulin test. So that is what clinches the diagnosis. A positive antiglobulin test tells you that the cells, the red cells in that recipient has been sensitized. They've been exposed to something they're not supposed to be exposed to. Now, the urine should be examined for hemoglobinuria as different from hematuria. Blood chemistry is supposed to be done, renal function, markers of hemolysis should be ordered, serum, the bilirubin levels, the LDH, the aptoglobin levels, which is going to drop. It's important to order microbiologic cultures because you need to rule out a septic transition reaction, which is a differential in this instance. The coagulation profile is very important, and then it's important to have a full blood count. Now, I should reiterate that acute hemolytic transition reaction is a hematologic emergency and should be treated as such. Now, how do we treat this kind of patient? One, cease the blood transfusion immediately. Immediately stop the transfusion. It's important to maintain a very good IV access. Possibly 2 large bore cannulas should be sited in this patient. It's important to institute isotonic hydration with ringers or with normal saline. And it's important to change the IV, give the blood giving set or the IV giving set, as the case may be. It is important. You cannot afford to use the same blood giving set containing the allogenic blood, to initiate any other kind of treatment for this patient. Now, it's important to redo the identity checks. You need to check the patient's identity, check the patient's wristband. If your facility uses wristband, you need to check the patient records and look at the compatibility of the release form and be sure that there is a tie, between them, there is a match between them. If there's any discrepancies, then that can be where the problem is coming from. Now, the following needs to be returned to the blood bank. The discontinued blood unit and its tubing you cannot discard that tubing. The discontinued blood unit with its tubing needs to be returned to the blood bank, and then the patient's post-transfusion sample needs to be collected and also returned to the blood bank. Now, this requires multidisciplinary care. Oxygen therapy is indicated. You need to give antipyretics. You need vasopressor therapies. We tend to run from very aggressive vasopressors that can induce hypotension in the renal system or the renal vasculature. So things like adrenaline, we tend to run away from them. But dopamine, low dose dopamine, or as the patient requires. For an established DIC, of course, you need to institute a DIC protocol. You need to ensure you replace the coagulant proteins. You need to optimize the platelets with platelet transfusion. You need to monitor these labs and the vitals of the patient closely. And then you still need, because this patient is going to have transfusion refractoriness. The hemoglobin pre-transfusion might have been 7. By the time you have a hemolytic transfusion reaction on your hand, this hemoglobin might crash to 3 or 4. Which puts the patient in a very dicey state. And of course, you need to optimize the patient's hemoglobin with group identical blood units for transfusion. Now, the next one I'll talk about are the allergic reactions. And these occur in about 1 to 3% of all transfusion. They are more common in individuals that have atopy or that have family history of familial tendencies for allergies. Typically, they present with local or some sort of systemic urticaria rash, and then it's erythematous and then pruritic. It's quite pruritic. And then what is happening here is that this patient or transfusion recipient, before now, have been exposed to allergens in whatever form, and they've developed antibodies, IgE, that is bound to their basophils and bound to their mast cells. Upon exposure again to these allergens, there is a trigger, and there is cross-linking of the IgEs that is bound to the basophils and bound to the mast cells, and there's degranulation of the mast cells and these basophils. And so there's release of histamines and prostaglandins, and then this is what triggers the urticaria rash that you see in this kind of patient. It can become severe, and when it becomes severe, we're talking about anaphylactic reactions. They can involve, other major organs. Now, please note that allergies do not always reoccur in subsequent transfusions. Because subsequent units of blood that you're going to give might not contain the allergen that the patient is being exposed to, and it's not associated with fever. So this is how you differentiate allergic reaction from febrile non-hemolytic transfusion reaction. Now, how do you manage allergies in transfusion? You need to cease the transfusion temporarily. You need to give antihistamines to control the urticaria, to control the itch and the pruritus. And then there is a role or place for use of the newer antihistamines because they are less sedating. Now, transfusion should be resumed within 30 minutes if the symptoms abate. And then in very severe cases, the transition of that injection needs to be stopped completely. And then some patients might experience hypotension, might experience facial edema. And then at that point, you need to start introducing pressors, adrenaline. And then for subsequent transfusion, you want to plan around pre-medication with antihistamines. And then you also want to wash the red cells. So they are red cell washers. And then by the time you have 2 or more serious allergic transfusion reactions that are unresponsive to antihistamines, you want to wash red cells. The risk with that is that if you don't have a red cell washer that maintains a closed system, you're going to introduce bacterial contamination or any other form of contamination, and that is a higher risk to the patient. Now, anaphylactic reaction is just the end of the spectrum in allergies. The same pathogenetic mechanism, IgA, degranulation of mast cells and neutrophils, and then what you then have is affectation of other organ systems. Principally, can affect the cardiovascular system with hypertension, can affect the GIT with increased GI motility. And then one of the things that can happen is that a shock would, by the time a shock happens, now shock occurs because of newly synthesized chemical mediators that occur from this same allergic process. And of principal importance is the platelet activating factors. These are very known to upregulate NO production. And as you know, nitric oxide it relaxes, it helps to maintain the vascular tone, helps to dilate the blood vessels. And so by the time there is vasodilatation, and this occurs on a systemic level, there is going to be pulling of blood to the periphery, and that's going to precipitate the anaphylactic shock. Now, there is difference between anaphylactic reaction and anaphylactoid reaction. And so it's important to note that anaphylactoid reactions are different from anaphylactic reaction. Now, anaphylactoid reactions occur in the setting of IgA deficient blood recipients. And then when you have these individuals who are IgA deficient, they are quite rare. IgA deficiency occurs in just about 1 per 700%. And then some of them would develop anti-IgA because they are negative for IgA. And then by the time you're exposed to a blood component that contains immunoglobulin A, there's going to be formation of IgA, anti-IgA complexes, and that is going to trigger the complement pathways. It's going to trigger the classic complement pathways, and then there's a generation of these, anaphylactoxins. I mean, there are different kinds of complements, and they do different roles. There are the opsonins, they are the ones that mediate immune adherence. There are the opsonins, but this particular one, C3A, C4A, C5A, they are anaphylactoxins. They are able to provoke massive dilatation of peripheral vessels. They are able to increase vascular permeability, and there's going to be pulling of blood in the periphery. And then what you're going to have from that is going to be a shock. And so anaphylactoid reactions are different from anaphylactic reactions. Typically, the onset of symptoms is very rapid within minutes. And then various organ systems can be involved. You can have the skin, urticaria with erythematous eruptions, respiratory difficulties. They're going to develop stridor from bronchospasm and laryngeal edema with wheeze and cough and respiratory distress. They're going to develop hypertension, and as part of the compensatory mechanism, there's going to be some tachycardia because the heart is going to work more to compensate for this acute shortage in volume in the central circulation. Now, GI side effects too can manifest, and then let's note that this reaction, anaphylaxis, is actually an emergency and warrants an ICU care. How do we manage this? Pressors. You need to maintain blood pressure in these patients, and that requires pressor drugs. You need to, put in a central venous pressure line to be able to monitor the pressure in the right. It's like a surrogate for pressure in the right atrium. You need to give supplemental oxygen as required, maybe about 4 liters of oxygen per minute. You need to intubate this patient in events of laryngeal edema with obstruction. This patient needs to be kept alive. The only way you can oxygenate this patient is to intubate this patient. Sometimes you might need to, if patient is retaining CO2 already, and ventilation or respiratory efforts are poor, ventilation is not well achieved, you would need to put this patient on a ventilator. And if intubation is difficult because of laryngospasms, you might need to do a cut down, a cricothyrotomy or some sort of tracheostomy tube in order to be able to oxygenate or ventilate this patient. Now, wheezing can be managed with, beta-2 agonist albuterol. You might need to give aminophylline. Urticaria can be managed with glucocorticoid. Now, for subsequent transfusion, you should try and wash whatever component you are giving if that technology is available. And then, if plasma is needed, it has to be IgA deficient plasma in order to avert this kind of reaction. Now, the next one I'll talk about are the transfusion-related acute lung injury. Now, this is technically defined as a new lung injury. So it's not pre-transfusion, it's a new occurrence that develops with a clear temporal relationship to transfusion in patients without risk factors for acute lung injury. Now, TRALI is what we call it, and it's non-cardiogenic pulmonary edema, and it's typically associated with infusion of plasma containing blood components. The usual setting is that of blood donations, obtained from multiparous women. And then the incidence is about 1 in 5,000 or 1 in 5 to 10,000 transfusion. Now, what happens here is that you have these local agglutinins in the donor blood. So these are, for instance, mothers who've carried multiple gestations or has carried many babies. They've been exposed to all sort of antigens in the babies, and then they formed these local agglutinins. By the time they're infused, blood from such a person is infused into a recipient of blood. It then induces agglutination of leukocytes. Typically, it affects the leukocytes within the recipient, and then sometimes it can affect leukocytes in both recipient and the donor. And then it causes obstruction, microvascular obstruction, and injury within the pulmonary vasculature. And all of this resultant endothelial damage, alveolar damage and inflammatory changes is what underlies the entity called transfusion-related acute lung injury. Now, the typical presentation is that it occurs within 2 hours or sometimes up to 6 hours of transfusion initiation. You're going to find sort of triad of fever with chills, and then they're going to have some respiratory distress or difficulty and hypotension. If you see fever in the patient intra-transfusion, you see dyspnea or respiratory difficulty or cough, and then you see hypertension. Trally should come on top of your list. Now, how do we confirm this? You need to have a chest radiograph, and then you're going to see new bilateral pulmonary infiltrates, and it's not associated with any sort of pre-existing or current cardiac compromise or volume overload, and that clinches the diagnosis. How do you manage Trally? Now, this requires HDU care in some of the instances. You need to provide supportive care. For the fever, give antipyretics. For the respiratory difficulty, give oxygen therapy. Typically, will resolve in about 3 to 4 days, and then you do not need any sort of diuretic therapy or diuresis for Trally because the etiology is not cardiogenic, is not volume related, and then sometimes too, steroid therapy is not indicated in this kind of diagnosis. And then in terms of prevention or preventive tip, you might want to avoid blood from female donors and then give blood units from male donors. Now, the other one I'll talk about is the septic transfusion reaction. This is another potentially grave reaction. If you've seen this before, you will not want to transfuse blood to anybody. You will need to justify the use of blood before you infuse. Now, this is life-threatening and it typically results from bacterial contamination of blood units. How do bacteria get into blood units? One, asymptomatic bacteremia. So some donors can have asymptomatic bacteremia. They just have this bacteria in their bloodstream. Bacteremia is separate from septicemia. Asymptomatic is just there, docile. And then if it's infused into somebody who doesn't have the level of immunity, it can escalate. It can be through contamination during the collection process. It can be during, blood processing, blood component processing, and then you are deploying a sort of open system, and that's why we always emphasize the need to use blood tillers so that you can maintain a closed system. Now, septic transfusion reactions, they are commoner with platelet transfusion, and the simple reason is because platelet is stored at room temperature compared to red cells that are stored refrigeration at about 2 to 8 degrees centigrade. Now, typical organisms that you will see in red cell contamination is psychrophilic or cryophilic organisms like Yersinia enterocolitica with a lot of toxoid or toxin production. In platelets, you typically culture things like staphylococcus or coagulase negative staphylococci, the diphtheria and other skin commensals. Now, how do we diagnose septic transfusion reactions? One, this patient will present with high-grade fever, with chills and rigors. There's going to be tachycardia, there's going to be hypertension. And I've seen this happen. And within 15 minutes, a patient is crashing before you. There's going to be dyspnea, there's going to be some gastrointestinal disturbance, and this can progress rapidly to DIC. Now, typically symptoms will evolve during the transfusion episode or intra-transfusion, and then usually commences within about 15 minutes. How do you manage this? In suspected situation, you need to cease transfusion immediately. It's important to notify the blood bank immediately, and then microbiology cultures need to be initiated. You need to take samples for culture. Samples for culture needs to be taken from the blood unit, and then needs to be taken from the patient as well, and they are sent for appropriate cultures, aerobic, anaerobic. You need to have institution of broad spectrum antibiotics, and that should commence after the culture samples are taken, and then you need to aggressively support this kind of patient. I've seen a few of them recover, but always a very fierce battle. It is rather prevented than experienced. Now, septic transfusion reactions, how do we prevent? There's some general tips, in terms of preventing this. It's important to ensure a stringent process in the collection process, do a thorough donor hand cleansing. Now, it's been shown that diversion of the first 20 to 30 ml of blood into a pouch. Some of these kits have a diversion pouch. If you look at an apheresis kit, you are going to find a diversion pouch in there. Now, if you divert that can reduce contamination of blood component as much as 70%, and that's quite significant. Now, it's also important in terms of prevention to do some spot checks, of your blood. You can take intermittent checks and culture some of the blood units, and then you can do visual inspection. This is a must before every transfusion. You need to do a visual inspection of the blood bag. Look out for flocculation, look out for visible growth of any organisms within the blood bag. Look out for any change in plasma coloration, and this can be subtle signs that you are dealing with a contaminated blood, and such kind of blood unit must never be infused into patients. Now, it's also important that platelet components the storage must not exceed more than 5 days. Training. I've watched tons of people in collection processes, and sometimes we have to remind ourselves that, look, you need to clean thoroughly with the acceptable disinfectant to ensure that we reduce the chance of any sort of septic transfusion reaction. And then careful donor selection. If you are taking blood from IV drug users, the risk is high, because these are people that push needles unsterilized into their bodies all the time, and the risk of bacteremia is high in such kind of persons. Now look at transfusion-associated circulatory overload. This is life-threatening. Again, this is life-threatening. At particular risk are neonates. These are, categories of individuals with very low cardiovascular reserve. So neonates, extremes of age, elderly patients, extremes of age, patients with cardiac or renal disease, they have lower cardiac reserve. They're able to tolerate less stress, because of the cardio-renal or the cardiopulmonary compromise that already exists in their system. Now, etiology is as simple. There is volume overload, there is congestion and sogging in the lungs, and there is pulmonary edema. The patient is going to be breathless. And then this is what happens. It is called TACO, transfusion-associated circulatory overload. Now, this would occur from large volume transfusion. So if you need to give massive loads of FFP to a patient, for instance, with DIC, you might be trending around this kind of corridor. If you give blood components with osmotic load, you might need to watch out for this kind of, complication. So you should be able to preempt based on the kind of protocol or treatments you're giving to the patient. Now, how will this patient present clinically? Now, cough, respiratory distress, there's going to be elevation of jugular venous pressure. They will have diabetic crepitation, tachycardia, hypertension because of volume, and then they would have widened pulse pressure. Now, if you want to investigate them, you can do their the BNP levels. BNP is going to be released because of increase in ventricular contraction, sort of stress on the ventricles, and they're going to throw out more BNP there, and that is going to clinch the diagnosis for you. Now, how do we treat? In principle, transfusion should be discontinued because you don't want to give more volume to the patient, and then you need to initiate transfusion or initiate treatment for heart failure, CCF, or incipient heart failure. You need to down rest. I mean, this is a mainstay treatment. You need to give some loop diuretics to be able to expunge fluid from this patient. You need to nurse in cardiac position, and then oxygen therapy may be implicated. How do you prevent TACO? Identify the at-risk patients. You need to slow the pace of transfusion, except in emergency. So for elderly people, you might want to pace the transfusion, at a much longer interval. You need to pre-medicate. So sometimes you see us giving furosemide pre-transfusion, and then for situations or decisions warranting immediate reversal of warfarin overdose, where you've had some sort of over anticoagulation, you need to reverse the effect of warfarin. It is better to use smaller volumes or use components, more specialized components like the PCC, compared to giving large volumes of fresh protein plasma. And then for choice of blood component, like I emphasized at the start, what we preach and practice now is blood component therapy. If you see anybody doing whole blood donation, something is wrong somewhere. There are only two reasons why we still defer to whole blood transfusions. Outside of those two reasons, and those two reasons don't even make up to 1%, or let me say, doesn't make up to 5% of our transfusion need. So on no reason or account should you give whole blood. And then if you need to transfuse patient, if you give packed cells, you're talking about 200 ml of blood as compared to 450, 500 ml of blood. And so the volume exposure for the patient is less and the chance of TACO is less. Massive transfusion occurs when a blood recipient has received at least one blood volume within a 24 hours period. Now, I want to sort of emphasize that by the time you are replacing one blood volume, dilution effect sets in. You're going to dilute the coagulant proteins. You're also going to dilute the platelets, the thrombocytes in this patient. And by the time that's sets in, you are setting the body for a cascade of bleeding sequelae. So this is one thing that we need to be worried about. Now, by the time you expose a patient to blood, multiple units of blood. So, for instance, a 70 kg man who has received 10 units of transfusion, red cell transfusion within the last 24 hours qualifies for massive transfusion. And you're going to have exposure to metabolic changes in the blood. You're going to have exposure to citrate because blood is stored with citrate. CPDA oftentimes is what we use around here. And so citrate is going to be, is going to mop up calcium. That's the mechanism of action. And then you're going to have hypocalcemia, and patient can have quite symptomatic hypocalcemia. You're exposing the patient to lots of blood, and these are blood that have been stored for a while. You already have leakage of potassium, which is likely intracellular into the blood bag, and then you're going to have heightened levels of potassium in this patient. You're going to have hypothermia because these patients are being transfused with blood that are brought from cold, from refrigeration. So you need to watch out for these signs: perioral tingling, facial numbness, muscle twitching, cardiac arrhythmias. This can all happen, from symptomatic hypokalemia. Hyperkalemia can be quite symptomatic, from arrhythmias to paralysis and sudden death. Hypothermia as well can induce cardiac arrest, can even provoke a DIC. And so we need to manage this sort of problem. And this leads us to what we call the massive transfusion protocol. This protocol is a preemptive approach to managing potential outcomes or potential adverse events of massive transfusion. And now there are indications where you might need to massively transfuse the patient. A road traffic accident that has lost 80% of the blood volume. That patient is going to die if you don't do anything. Look at an obstetric case, an abruptio placenta that has ruptured and is, oozing out blood, is pouring out blood. That patient is going to die except you do something. Now, in those kind of patients, if you have to do something, then you have to preemptively manage for potential complications of massive transfusion. So typically, there are different protocols you're going to hear or see about. By the time you are giving this number of blood units, you need to add this number of platelets and this number of FFP to the transfusion. So this is what this protocol talks about. Now, the next transfusion reaction I will discuss is actually the delayed hemolytic transfusion reaction. Now, they may be primary or secondary. They typically would occur within 1 to 2 weeks post-transfusion. Primary forms occur without prior antigenic sensitization, and then they can occur up to like 28 days post-transition, typically mediated by IgE antibodies. And then most frequently indicated or implicated blood group antigen systems are the RH, the KEL, and the KIT antibodies. Now, that's a subtle difference between the DHTR and then the DSTR. Now, they're usually mild, moderate in terms of intensity, but by the time you do not have any clinical evidence and all you have is a serologic confirmation, your direct antiglobulin test is positive, and then you're able to identify that there is antigen mismatch or discrepancy between the recipient and the donor, this passes for a delayed serologic transfusion reaction. It's difficult to estimate because of the very low, because of the very mild, severity. And then by the time you see a triad of fever, the patient develops fever, mild fever, which you just manage. The patient has had some jaundice or some worsening jaundice, or the patient has been transfusion refractory. So you're giving a patient at HB of 7 grams per deciliter, you're giving that patient 2 units of red cells, you expect the HB to be about 9, and the HB is still 6.5 or 7. That is transfusion refractoriness. And then this is telling you like we might be dealing with some sort of delayed hemolytic transfusion reaction in the patient. Now, I'll just keep this, but one thing I would emphasize here, and that is why in the blood bank we'll request for fresh samples so that we also understand on the clinical side. If you've transfused a patient and your transfusion, the last episode of transfusion is in excess of 72 hours, 3 days, we would typically require that you send a fresh sample for cross-match, because that patient has been exposed to antigens, in the preceding days, and it's possible that patient has formed antibodies that was not captured in the previous cross-match. And so it's important that we collect fresh sample and use the fresh sample in the new cross-match process to prepare more units of blood for the patient. Now, red cell alloimmunization, I think this is a bit more academic, and the clinical sequelae typically with things like delayed. This is what underlies things like the delayed hemolytic transition reactions, the acute hemolytic reactions, and then hemolytic disease of the fetus and newborn. It's just talking about a mismatch. And then once you have exposure to foreign or non-self antigens, there's going to be antibody formation, and that is what we call alloimmunization. Now, how do we manage that? Well, deploy protocols to ensure you have antibody screening in your facility, and then if you pick atypical or irregular antibodies, you should be able to identify them, and then do a careful selection and provision of antigen-negative units. And then you need to also ensure a closer donor-recipient matching, especially in patients that are multiply transfused. And then it's also important that antenatal and postnatal anti-D prophylaxis should be offered to RHD negative mothers carrying RHD positive babies. Now, this is platelet alloimmunization. I think I'll just touch on it a little bit because I'm running out of time. Now, at-risk patients are patients that receive frequent transfusion, typically implicated at the HLA antigen and antibodies. And then you also have the platelet-specific antibodies. They may also be implicated, the HPA1A and all of that. Now, the clinical sequelae of alloimmunization to platelet is transfusion refractoriness. And then transfusion refractoriness can be twofold. It can be immune and non-immune. Immune causes are things or situations that increases your platelet needs when there is an increased demand because of specific entities or specific situations in the patient. So fever would increase platelet demands. Splenomegaly will lead to pulling of platelets within the spleen. Sepsis will increase platelet consumption. Bleeding will increase platelet needs. So all of these kind of entities are non-immune. Now, in the immune one is when there is antigen-antibody reaction, and then these platelets are mopped up and destroyed by the reticular endothelial system. Now, we usually assess platelet refractoriness with the corrected count increment. And then I'll just sort of demonstrate what it looks like. There are different ways to get platelets. If we're doing the apheresis platelets, typically the yield for platelets is about 3 to 10 raised to the power of 11 in that apheresis bag. And then usually for the random donor platelets that we harvest from cold centrifugation, typically about 5.5 times 10 per 10 per bag. Now, if you, for instance, transfuse the patient with apheresis platelet, and then you do your post transfusion increment, your post transfusion increment is the post platelet count, minus the pre-platelet count. So your platelet pre-transfusion was 40, or let's say 20, and then your platelet count post-transfusion is 60. So take 60 minus 20, that is 40. And then we correct it for the body surface area, for the body size of the patient, and then the platelet yield. So that is multiplied by the body surface area divided by the platelet yield. Now, if you have CCI, the correct count increment less than 7.5. Now, this is variable depending on which authority you are putting, but on the average, typically CCI at 1 hour or 15 minutes to 1 hour is usually between 5 to 10. But take, for instance, the CCI in the patient is less than 7.5. That has occurred on 2 occasions. You are dealing with platelet refractoriness. If at 24 hours you do your the post-transfusion increment, and then you're having a CCA of less than 4.5, you're dealing with platelet refractoriness at 24 hours. How do you manage that? I think I will skip that. We do not even do cross-match. Yeah. So the other entity is the post-transfusion purpura. Now, this is just some immunologic destruction of transfused platelets, and they're going to just present with purpura, typically occurring up to like day 12 or day 7 after transfusion. Diagnosis is confirmed by platelet alloantibodies, and you can actually do this. These assays are not readily available, but you can do the monoclonal antibody mobilization platelet antigen is a capture assay, or you can do the platelet anti-immunofluorescence assays to be able to pick some of this. I'll skip some of these things. Now, the other one I think we should mention is the transfusion-associated graft versus host disease. This is graft versus host. The host is the recipient. The graft is the blood transfusion you're going to give to the patient. So what you're seeing is an immune attack by immunocompetent T cells, donor T cells, on the host, and that's the recipient of the blood. And then you have some sort of engraftment within the host tissue, and that can affect any organ system actually. But typically, it's going to go for the skin, it's going to go for the liver, it's going to go for the bone marrow, and this is where you see the manifestations of graft versus host disease. Now, this is a very cerebral entity, because as many as 90% of affected persons will actually die. So clinical presentation, fever, rashes, skin involvement, diarrhea, GIT involvement, liver dysfunction, cytopenias, bone marrow involvement typically would occur within 1 to 6 weeks of blood transfusion, for which no other apparent cause has been found. How do you diagnose this? Tissue biopsy of affected tissues, skin biopsy, liver biopsy, or bone marrow aspiration. And then sometimes we do the chimerism studies to see the proportion of donor cells within the recipient. And once you have this, that confirms your diagnosis. Treatment is largely supportive. These patients are typically unresponsive to immunosuppressive therapy. So you give them ATG, antithymocyte globulin, you give them cyclosporine, they typically do not evolve. They are like a time bomb waiting to happen. And the prognosis is very bad. 90% of them won't survive this. Prevention still rests on irradiation. That's why if you're going to treat at-risk patients, so at-risk patients are patients that are immunocompromised. At-risk patients include cancer patients. At-risk patients include unborn children, and you have to do intrauterine transfusion. This kind of blood component has to be irradiated. You do gamma irradiation at 25 grades for high-risk patients. Now, transfusion siderosis is another very important one. I think this slide is self-explanatory, so that I skip and in interest of time. But what we're saying here is that if you have to transfuse patients over time, you are loading them. And the body doesn't have any exact or active physiological mechanism for expunging iron from the body. So if you've given patient, for instance, about 20 units of red cell in a time interval, you've loaded that patient with about 4 grams of iron. And this is roughly, the total body iron is about 5 grams. If you look at iron metabolism, you have, distribution of iron in different body compartments. And then the storage compartments, ferritin stored as ferritin and hemosiderin. By the time this is full, it begins to extend into parenchymal tissue. And this is what we describe as secondary hemosiderosis, where you have the transfusion leading to siderosis, and you have deposition of iron within different parenchymal tissue. Largely affected parenchymal tissue would be things like the liver, so it can cause or induce liver damage. Cirrhosis can progress to hepatocellular carcinoma, can be dilated cardiomyopathy. The endocrine organs are affected with diabetes mellitus, hypothyroidism, or hypogonadism. You can have this bronze diabetes, where you have this skin hyperpigmentation because of iron deposition. The treatment typically is that we chelate. We have to take out iron from this patient. We are quite familiar with deferoxamine, which is the oral form. Deferoxamine is associated with things like pain at the injection site, and then there are situations where we want to prefer one to the other. A patient with nephropathy, for instance, will probably want to run away from deferoxamine. Now, the other one I think I should discuss is TTIs, and this is probably going to be my last round of slides. Now, TTIs are transmission-transmissible infections. They can be bacterial, viral, or parasitic. Bacterial contamination has been discussed much earlier, but some of the notable viruses are things like the hepatitis viruses, hepatitis B, hepatitis C to be precise, the human immunodeficiency virus, the HDLV1, HDLV. These are viruses that can be transmitted by blood and blood components. Now, TTIs also include parasitic infections, although we don't typically go for them. We don't typically screen for malaria. We don't typically screen for Babesia, Leishmania, Trypanosoma, Toxo, Mycofilariae. But again, it's important to also know that they are the emergent pathogens. So we have Zika virus, which can be transmitted by blood components or blood transfusion. You have the West Nile, you have the human herpes virus 8, which is implicated in Kaposi, if I remember correctly. And then, of course, you have the Brown diseases, causing all sort of encephalopathies, and it's important to note them. So how do you prevent TTIs? You need to have testing. You need to, have a foolproof technology that, if possible, will be 100% specific, and sensitive, to be able to pick these pathogens that can impact negatively, have adverse effects in transfusion. You need to adhere to donor selection criteria, because that way you can weed out a lot of risk, and then you can deploy pathogen activation techniques. You can, ensure the standards are there and they are maintained, and they should be informed by epidemiology pattern. What is the burden of this particular TTI? What is the pattern that you're seeing? Is there availability of a requisite technology in order to be able to screen these TTIs? And then what's the cost of blood supply? Now, just as a generic, approach, how do we prevent these adverse events? One, I've said here, we need to have donor screening advancements. We need to be able to screen our donors in a more defined way in order to reduce the risk of any sort of adverse events. We need to look for safe donors. That's all I'm saying, or that's all we're saying here. And then we need to have improved testings for TTIs that will pick if this the TTI screening says it is positive, it's positive. If the TTI screening says it's negative, then it's negative. That's the kind of foolproof technology we need to deploy. We need to ensure it's nothing but blood component therapy. Give the patient only what the patient needs. A patient needs correction of hemoglobin deficit. You need to give red cells, pack red cells. That patient has no business collecting no blood with plasma that the patient does not need and is going to cause all sorts of reactions. You need to automate your data systems, if possible, barcoding, patient wristband identification, transport thermometers. These are all sorts of technology you can introduce in order to improve transfusion outcomes. You can deploy transfusion information systems for your blood bank. Research and development are ongoing, and then there's a lot of research that can be done around some of this in order to improve outcomes. Effective occurrence management system. You've had a reaction. How did you manage it? The idea of occurrence management is that you want to do your error prevention. You are not just reporting the error for the sake of reporting. You are reporting the error because you want to understand the root cause. With your root cause, you can do your corrective action, your immediate remedial action, and then have a preventive action in place in order to prevent a recurrence of what has happened. So a patient has had this occurrence, it shouldn't happen again. There are some incidences that should not happen again. They are sentinel events, they are associated with death and disability and should not happen. So what occurrence management system do we have in place? What do we ensure judicious use of blood, and are we tracking these things? It's important that patients are educated and consent is given for transfusion. There has to be continuous professional development across the entire value chain. There has to be clear institutional, regional, and national policies. And then we need to monitor. Vigilance, we need to be vigilant. That comes through audits, exercises, external audits, internal audits, witnessing. And then we should also listen to our patients. We should listen to patient relatives because these experiences are quite helpful and phenomenal. And they say feedback is the food of champions. Now, in my final words, I would say that if we can go home with these three things, that blood safety is a collective effort. I think we've made a good bargain here today. Transfusion safety is not negotiable. And then transfusion policies, processes, and protocols must be adhered to in the patient's best interest. Thanks a lot for listening. I hope I'm still audible.
You're still audible, Dr. Adewin, but I think LSBTS is trying to say, okay, she's unmuted now.
Okay.
A very big thank you to you, sir. I did say it was going to be an interactive, informative session. We'll know you will have questions from all that we have heard from our speaker. Please send in your questions to the question and answer box. Answers will be supplied to these questions accordingly. We'll be going in for our interactive panelist session now. All aspects of medical care are being involved in this panelist session. We have Dr. Akinlemibola. He'll be giving answers to some of the questions as regards to adverse effects in his practice. We'll be having Mrs. Sarah Stevens, representing the private arm, the medical laboratory scientist. We're having Mrs. Adebukola Cole, a nurse, who will be also answering questions. And last but not the least, Mrs. Nneka Rashidat. Please, the first question goes to Dr. Akinlemibola. The question: what are the commonest adverse effects in the practice, in your practice, I think, and in any process or guideline in place of your facility for the management of blood transfusion reaction?
Thank you very much. I I'm Dr. Akilemi Bola. I practice medicine in Lagos, and my practice is in Agege. I'm also the chairman of the Association of Nigerian Private Medical Practitioners of Nigeria. And I want to thank Lagos State Blood Transfusion Service for, giving me the opportunity to, to be available for this panel session. I also want to thank our lecturer that has been on for a while. I've truly enjoyed his lecture. More importantly, I was thinking that he should go on and on and on and on. But I want to thank everybody for this. The answer to the question that you have is that the most common type of transfusion reaction that we have, at least the one that I'm with my experience, fever, which is either the one that will come immediately, an acute fever, or the delayed one, which can also occur up to 4 or 5 days after the transfusion. There is also a possibility of a chill. That is also one of the things that we notice in private practice. There could be urticaria rash. There could be also itching. Most of these ones are the ones that can be resolved within a short time, but it could even get even worse, though we hardly experience that in my practice. And that is that the fever could be very high and become uncontrollable. It could degenerate, and then we have a situation where you have hypertension and you have patients passing red urine, that is hemoglobinuria. And it could also be, the hemoglobinuria could be just transient or a massive one. And as soon as that happens, then we know we are dealing with something more serious than just something that we gloss over. In my practice, we have a protocol for blood transfusion. Usually we'll do that, and as soon as we want to transfuse, there's always this protocol that we use in ensuring that we transfuse appropriately. Some of them are checking the expiration date of that blood to ensure that it is still good for transfusion. We also need to check if it has been properly cross-matched with that patient. So we need to be able to also match that blood that is in the individual's hand and the patient, and to ensure that, yes, it has been cross-matched against that patient. We also need to check the logo of the Lagos State Blood Transfusion Service to ensure that, one, it has been tested and certified okay for transfusion by Lagos State Blood Transfusion Service. Also, we're also, part of the protocol is also to ensure that it is in form of, it is in form prescribed by the doctor. That is, what kind of, in what form the blood is prescribed by the doctor to be transfused. Is it a whole blood? Is it a part cell? And so on and so forth. We also need to cross-check that, and that is part of the protocol that we have. And then the more important one that is also very relevant to what we are talking about here now is the case of in the case of reaction. We have a protocol for the case of reaction.
Case of reaction.
Yes. When there is a reaction, of course, we will have lectured, tutored whoever is going to transfuse the patient about what to look out for you to be able to say that it's a reaction. And some of those things that we have discussed like before, like in the case of, is there any temperature? How high is the temperature? Is there any urticarial rash? Is there any chill? And so on and so forth. So the person needs to also be aware of that. So in case of reaction, now when you have a reaction in the course, the attending nurse have been conversant with the reaction signs, symptoms, which has been enumerated above. Then immediately you have to stop the transfusion. Also, part of the protocol is that you also need to inform the doctor immediately. You give antihistamine, and then when you stop the blood transfusion, including the line, you also need to exchange that blood with normal saline, and also ensure that the line that you are giving is also flowing well. You also need to take a blood sample, a new blood sample from the patient to ensure to take to the lab. You also need to inform the lab concerning the reaction that you are having. In our practice, most of the time it is as a result of the fact that yes, we tend to transfuse whole blood more, and by the time we inform the patient, the laboratory, and we find out that the reactions are transient, what they need to do is what they normally do is to remove the plasma and give red cells alone. And by the time you do that, the reaction usually is not progressive, and then you can have it. But also in severe cases, you also make available hydrocortisone for that. And then you begin to monitor the vital signs, especially the blood pressure. You also need to, as I have said, you need to inform the laboratory. The laboratory will take the blood sample away. If it is necessary, then they will, remove the plasma, and then take. Once it is removed, and once there is no continuous reaction of the patient, after waiting for a while, then the blood can be retransfused with red cells alone. And with that, most of the time we don't have much challenge concerning blood transfusion. Thank you very, very much.
Then questions from the speakers today on the adverse transfusion events should be sent to our question and answer box. They will be attended to there. So our second question goes to Mrs. Sarah Stevens. How often do you investigate the transfusion reaction? And what are the efforts put in place to prevent adverse events as a scientist? Please, Mrs. Sarah, you will have 2 minutes to answer this question.
Okay, good afternoon, everyone. And thank you to LSBTS once again for this opportunity. So the first question, how often? So we investigate transfusion reaction anytime it is reported. So as regards the frequency of that report, I think lately we haven't gotten, but when we first started the SINLAB blood bank, we used to get at least a transfusion report, like let's say maybe twice a month or 3 times a month, depending on like the volume of transfusion that it's done that month. So that's how often, and as soon as we get any report like that, we do our own in-house investigation. So I would say twice a month. And the second question is, what are the efforts put in place to prevent adverse events as a scientist? So what we've been able to do in the SynLab blood bank that we currently the blood bank that we currently manage for in maternal and child facility is that we do monthly decontamination of the blood banks. So we ensure that we decontaminate the blood banks every month, and we have 2 blood banks at the moment. So when we need to decontaminate one, we move the blood to the other one and like that, so that at no point in time is the blood left at room temperature at any time. The cold chain is always maintained. So the second one, which is actually supposed to be the first one, is that documentation and paying attention to details. I think Dr. Adewoye also mentioned it. It's always documentation is very key. And part of documentation, when you're documenting, you need to pay attention to what it is that you're doing, because as it can seem very basic, right? But then we all know that any error, any clerical error of any sort can have serious negative impact on both on the patient itself. So always ensure that pay attention to details whenever we're working on any cross-match request at all. So ensure that there's no clerical error, there's no mistake. The names on the tubes is the exact same name on the request form for the blood. And then another thing we also do is, I think we've also tried to regular communication with the management team. And I think when we first started running the blood bank, a few of the challenges was that, so when there's a blood request form, right, the doctors don't always include the indication for the transfusion. So there's no way, so it's more like just asking for group and cross-match for this patient. So there's no clinical data for us to work with. But we've been able to engage more now with the managing team. That's from the requesting doctors, the nurses, and all of that. So there's a more freedom of communication amongst everybody that is managing that patient, right? So it just ensures that, so when we know the indication for transfusion, we're able to say, okay, let's say it's whole blood that will probably be preferred for this patient, or it's packed cells, especially packed cells. So our own knowledge on blood banking, we can also educate some of the managing team, so it's for better patient outcome. And then another thing is also, so part of, in addition to that, it also helps us to get past history of the patient that needs transfusion. So past history of the patient, if the patient has been transfused before, if there has been a transfusion reaction and all of that, they'll be able to have an idea of what it is to look out for. And then another thing we also do to ensure that to prevent this adverse reaction is that we ensure group to group an identical group cross matching, complete cross match. So when I say group to group, I mean like if the patient is make sure that we give A. If the patient is O, make sure we give O, because I think O positive, A positive can also take O positive. So we ensure that if the patient is A, we give A, and like that, so that it reduces the chances of any of these adverse events, because it's usually safer to give group to group than to give any group that's not the patient's own blood group. And also documentation, like Dr. Adewoye also mentioned as well. So documentation, I think that's also really key. And documentation in this sense, what I mean is actually ensuring that we have the accurate data. So like when a transfusion reaction is reported, we ensure that we try to do the root cause analysis. I think Dr. Adewoye also mentioned that in his teaching as well. So you do a root cause analysis to be able to say, okay, what immediate action did you take as soon as this was reported, and what did you do to prevent a reoccurrence? So that also ties in with hemovigilance. So we give that report to the LSBTS. We do like a monthly report on blood banking service. So anytime there's a reaction reported, whatever reaction was reported, we ensure that it is documented properly, and then we also hand it over to the BTS for LSBTS for proper hemovigilance. And we hand it over to the LSBTS hemovigilance team as well. So those are just a few of the processes that we've put in place to prevent this adverse effect. And I think I can say confidently that at least over the last 2 months, we have not had any reports of a transfusion reaction. So I believe that all of this has helped greatly to reduce adverse effects compared to when we first started in the SynLab blood banking service, compared when we first started. So that's it. Thank you very much.
Thank you very much, Sarah. So as a private practitioner, we should also take home some of the things obtainable in Sin Lab so that we would prevent transfusion reactions. Please, we will be taking the angle of a nurse. Our third question goes to Mrs. Adibukola Ko. What efforts have been put in place in identifying blood transfusion reactions? Please, ma, let's take note. We should limit answering our questions to just 2 minutes.
Good afternoon. Good afternoon, everyone. And I want to say a big thank you to Lagos State government, yes, and to Lagos State Blood Transfusion Services for this opportunity. I'm Paul Adebukola Oluwabusai. I'm the director of Lagos State. I'm the director of Nursing Services, Lagos State Health Service Commission. And I want to start by quoting Dr. Ademola Adewoyin. First and foremost, I say thank you for your robust lecture. He says blood safety is a collective effort. Yes, it is. Before a nurse who administer or involved in blood transfusion, then the nurse must follow a guideline, the blood transfusion protocol. At least there must be a request for the blood transfusion. There must be a reason for the blood transfusion that is known to the nurse and by a physician or a doctor. Also, if the patient is conscious, the procedure is explained to the patient, and some of the adverse effects is also told to the patient. That is the reason why the nurse too must be knowledgeable. The nurse also must check for the details, the group and cross-matching, everything that needs to ensure that there's compatibility of the documents and document them. Also, we need at least 2 registered licensed nurses in before the commencement of blood transfusion. The 2 of them will work hand in hand, and they're going to check for the screening certificates, the logo from LSBTS, then the labeling, and look for the following. Number 1, they want to see the serial number, the blood type, the resource factor, the collection date, the expiration date, and the screening of all the viral markers. We want to see if the blood is free from syphilis, hepatitis A, B, and C, HIV 1 and 2, etc. Why are we doing this? It's because we want to ensure that the blood is free from blood-carrying diseases and is safe for transfusion. Also, we need 2 licensed registered nurses in identification of the patient and document so that the right blood is given to the right patient. Also, the nurse must ensure that she takes a baseline vital signs before the commencement of the blood transfusion. This will serve as a guide: the temperature, the pulse, the respiration, and the blood pressure. If there is an increase in the temperature and the respiration in course of blood transfusion, that means there may be an adverse reaction going on. Also, the nurse must ensure strict aseptic technique that is maintained. Also, proper blood transfusion set with micron mesh filter is used to prevent the administration of blood clots and particles. The nurse should ensure that after each transfusion, the blood transfusion set is changed to prevent particles, to prevent blood clots also. Also, the nurse should ensure that giving of blood to the patient is at room temperature to prevent chills. Also, blood transfusion should start slowly within 15 minutes, because most of these reactions start within 15 minutes of blood transfusion commencement. So it should be slowly, about 15 drops per minute. The nurse should remain at the patient bedside for the period of 15 to 30 minutes because of adverse reaction. The nurse will continue the blood transfusion and also should be able to wash out and monitor, inspect the whole thing and chat with the patient to ensure that everything works out on and on. There might be an underline to continue normal saline 0.9% while the blood transfusion is still on. The nurse should ensure that blood should run maximum of 4 hours, especially for whole blood, packed, and cell. And but for plasma, platelets, and so on, this can go and run quickly for about 20 minutes because of the clotting factors. Then the patient is monitored, documented, and if there is any blood reaction of any sort, immediately the nurse will stop temporarily the blood transfusion. The nurse will not flush the line or the tubing. It is removed temporarily, and the physician is sent forth, and emergency management commences, and the patient is managed according to the symptoms and as has been told by Dr. Adewan. And on this note, I want to say a big thank you once again. Thank you for the opportunity. I appreciate you. And note that safety is a collective effort. Thank you.
Thank you very much, ma'am.
You're welcome.
So we are seeing what our practice should entail to avoid the adverse events in blood transfusion as a private practitioner, as a medical laboratory scientist, our duties as a nurse. We want to see what is obtainable in the public blood banks. Our last question to Mrs. Mecca Rashidat. What are the commonest adverse transfusion reactions investigated for? And what are the requests and report structure available? Mrs. Mecca, just 2 minutes.
Hello, good afternoon. I'm Mecca Rashidat, the HOD Blood Bank, Lagos State Blood Transfusion Service. The question number 1, what are the commonest adverse transfusion reactions investigated in our facilities? At times, when they fill the form, we realize they may put fever, rigor, chill, itching, or coughing. So most of the form filled by the doctors. And the second one is on what is the request and the report structure available. The request is that we have transfusion reaction form, which we employ all doctors to make sure they fill it. Because at times, the attendant may bring the blood back to the blood bank, claiming the nurses on duty claim there's transfusion reaction. So we always put on a note and tell them that they should do the normal protocol, where they will give us the patient's pre-sample, because we have the post-sample already with us. And we have form with them, which they can quickly document and send to us. And then if they do so, we make sure we regroup. We regroup both the pre and the post sample. We using forward and reverse grouping for us to ascertain that the blood group is okay. And we make sure we group, we cross-match again. After we cross-matching, we do DAT, that direct cool test on each unit of blood. The blood in the blood bag, the patient, the donor survey, the recipient sample. And we all make sure that after that, when all those things are in place, we make sure they realize that it was not the reaction will be due to maybe the management, that they should go back and do the necessary thing. But ever since the commencement of blood transfusion service in the Magada Center, we have only 2. We have one on September 1st, 2021, which after that one, there was another one March 10th this year. And ever since then, we don't have any transfusion reaction due to ABO or cross-matching. So with this, I believe if the doctors, all the nurses, all the medical team in charge of blood transfusion take to the normal process and they fill the normal form, everything will work hand in hand. Thank you very much.
Thank you very much, everybody. It has been a very wonderful period.
and I was excited to see some people logged in to be a part of this webinar. I need to say a big thank you to Dr. Agbe Davies. She was the former Permanent Secretary of Health, the Ministry of Health some years ago, and she was our former chairman of this board. Really thank you for being a part of this webinar. We thank Professor Fabanwo, the CMD of LASUT. He came with his entourage. I saw a lot of doctors from LASUT being part of this webinar. I also want to say thank you to Dr. Ubo from Port Harcourt, Dr. Shinowa from Premier Hospital. They've been a very, very great stakeholder in ensuring that we have a reduced incidence of blood transfusion reactions. I thank you, Dr. Remosu, and the LUT team. Dr. Remosu is a laboratory manager from Lagos University Teaching Hospital. Thank you very much for being here. And we had a lot of retired people here. Thank you, Mrs. Newton. Thank you, Mrs. Ajala, for being a part of this webinar. And finally, I really want to say a big thank you to the representatives of the Guild of Medical Laboratory Scientists. This is not a vote of thanks, but I just had to say this. You have been great support. So I will actually open the floor for Dr. Alori to say a big thank you, the final thank you to everybody.
Thank you very much, the Executive Secretary. It's a privilege once again for us all to come together under this webinar to do justice to some of those basic challenges that has been long overdue. I believe that the exhaustive presentation and the panel discussion has really added value to us as practitioners, both in the private and the public institution. It is my belief that the lesson learned will be put into practical use that help us improve in the quality of service and at the same time ensure that safe blood is transfused in Lagos State. And once again, I want to thank the leadership for organizing this quarterly seminar. And I want to appreciate the guest speaker for doing justice to this brilliant presentation. The panel of discussion and also the question asked showed that people have really participated in this webinar. It is my belief that we continue to improve in terms of quality assurance and even quality improvement. Once again, I want to appreciate you all for your attention. I believe that many more will love to attend this kind of webinar in the next quarter. And I believe that we are coming with a brilliant topic that will be helpful to all in terms of a quality blood transfusion service. Once again, I appreciate you all. Thank you.
My name is Mayene Oliver, and it happens that I was so sick to the extent that I couldn't even move my whole body. I experienced a very thick headache, and if I try to stand up, I feel like falling, and I felt very dizzy. So to the point that several tests was conducted on me, and coupled with the fact that that month my monthly flow came, and I was so confused. I felt very down. I thought I would die. I felt very scared though. So the doctor tested me, and I was admitted at the hospital. So he said that I needed blood, that my blood was very low. So they started looking for donors, and thanks to God, and the blood saved my life. Donate blood and save life.
What to look out for when your patient is about to be transfused with blood. Ensure the pint of blood is certified. All certified units of blood have been tested and have been found to be free of all transfusion transmissible infections. To know if the blood is certified, confirm there is a certification label attached to it. Also ensure you can see the logo of the Lagos State government on it. The same is applicable to other blood components, including the fresh frozen plasma and the platelet concentrate. This information is brought to you by the Lagos State Blood Transfusion Services.
What prompted me to start donating blood was because of a collapsed building at Itafaji, I think 3 years back. And getting to the hospital, they said the victims needed blood and there was no enough blood in the blood bank. So that was what motivated me to start donating blood. I donate 4 times every year. I've been donating since 2019. I will encourage them to start donating blood, that it doesn't kill. The more you donate blood, the more another blood flows in and you'll be healthy and fine. Donate blood, save lives.
A prize so priceless, a gift so expensive it only flows from the heart. Blood, the gift of life, when given, gives the giver a new glow, new cells to renew the functionality of tissues, organs, and systems. Givers of this gift always known to be fit. Donors, the true heroes in this feat. Excess iron given off and their livers revitalized. Immune system improved with risk of cancer reduced, possibilities of heart attacks lowered, and new blood cells produced. A gift, when given, that blesses the giver's life. Wouldn't you rather be one? Donate today, save a life, and that life might just be yours.
Orúkọ mi ni Abdulganiu Adéyẹmí Dòsùnmù. Mo wá láti ìpínlẹ̀ Èkó. Tí bá máa rántí, on the 10th January 2011, ìjọ yẹn ìyàwó ẹ̀gbọ́n mi fẹ́ bímọ, wọ́n dẹ̀ fẹ́ ṣe operation fún. Wọ́n fẹ́ ṣe operation fún, tí wọ́n wá lọ nídìí láti gba ẹ̀jẹ̀ yẹn padà. Ní inú ibi báyìí, ẹ̀mẹ́rin. Àǹfààní tó dá wà ń bẹ, ó ń jẹ́ kára jí pépé, kò ní sí àìsàn kankan lára, èèyàn máa wà alright. Ó máa bẹ̀rù àǹfààní tó dá wà ń bẹ, because lẹ́nu ọjọ́ mẹ́ta yìí náà tí ìyàwó tèmi náà fẹ́ bímọ, mo jàǹfààní pé mò ń fi ẹ̀jẹ̀ sílẹ̀ dédé, tínú mi dẹ̀ dùn sí, tó dẹ̀ fún mi ní ìwúrí àti tí máa ṣe sí, tí máa fi dàgbà. Ẹ̀jẹ̀ fífílẹ̀ dá ọ̀rẹ́ lọ́ máa fẹ̀jẹ̀ lẹ̀ o. Ó ṣara láǹfààní kẹ́dẹ̀ fi máa sèbù ẹ̀mí o.
I donate blood to save life. I've been donating blood since 2010, and right now I donate 4 times in a year. I donate blood to save life, and aside the fact that you are saving lives, it also reduces the risk of having liver and heart diseases. It also reduces the risk of having cancer disease, and it helps develop new blood cells and so many on. I donated blood because I was invited by a friend. Then he actually told me that donating blood saved lives, so I said, okay, let's go together. So that was actually my first reason of donating blood then. They don't need to be scared because each time you donate blood, aside the fact that you are doing yourself good, you're also saving other people's lives. Give blood to save lives.
Blood is donated from the donor clinics of hospitals. In Lagos State, we've got 28 public donor centers, which is resided in the general hospitals, as well as the Lagos State Blood Transfusion Service donor centers. When blood is donated, the blood is taken to any of the 8 screening centers in Lagos State. The blood is screened using a 4th generation ELISA technology to be sure that the blood is free of infectious agents like HIV 1 and 2, hepatitis B, hepatitis C, as well as syphilis. Once it is screened and deemed fit for transfusion, the Lagos State logo is attached to the blood to show and to certify that the blood has been duly screened through quality assured measures. Following the screening process, all the blood is stored at the blood bank waiting for the request for it to be cross-matched for transfusion. Once there is a need for blood from any of the hospitals, the request is taken to the blood bank with a well-filled form as well as blood in a plain bottle for the appropriate cross-matching processes. Blood isn't just given like that. Every unit of blood collected at the Lagos State Blood Transfusion Service is appropriately processed into blood components because we want you to know that each unit of blood can save 3 lives.
At times, we have different blood products and blood being requested from each hospital. They can request for whole blood, packed cell. If it is whole blood, this is how the blood it looks like. And any blood in Lagos State without this logo, you cannot issue it. And in case the doctor requested for fresh frozen plasma, which is another product, his own logo is different from the logo of the blood. Now, after that, then they proceed on the cross-matching. In the request form, the doctor can indicate if it's an emergency or full cross-match. The emergency takes 15 minutes, while the full cross-match takes 1 hour. And in Lagos State Blood Transfusion Service, all donor, of course, we do more of those voluntary blood donors. All units of blood collected from our voluntary donors, our team, right, we are all genotyped. That's why it's running the genotype of the blood now. And the patient from each hospital also request for genotype blood because of sickle cell patient or some patients who has pathological disorder. Then after the cross-matching with the normal process, we do at room temperature, you incubate at 37 degrees centigrade. After the completion of that, then you proceed to the record section.
So each unit that you donate can save 3 lives. And that's why we appeal to you that you be a lifesaver.
Donate blood, give blood,
Save lives. Save lives.
Continue to give blood, save lives.
What to look out for when your patient is about to be transfused with blood. Ensure the pint of blood is certified. All certified units of blood have been tested and have been found to be free of all transfusion transmissible infections. To know if the blood is certified, confirm there is a certification label attached to it. Also, ensure you can see the logo of the Lagos State government on it. The same is applicable to other blood components, including the fresh frozen plasma and the platelet concentrate. This information is brought to you by the Lagos State Blood Transfusion Services.
What prompted me to start donating blood was because of a collapsed building at Itafaji, I think 3 years back. And getting to the hospital, they said the victims needed blood and there was not enough blood in the blood bank. So that was what motivated me to start donating blood. I donate 4 times every year. I've been donating since 2019. I will encourage them to start donating blood that it doesn't kill. The more you donate blood, the more another blood flows in and you'll be already on fine. Donate blood, save lives.
A prize so priceless, a gift so expensive it only flows from the heart. Blood, the gift of life, when given, gives the giver a new glow, new cells to renew the functionality of tissues, organs, and systems. Givers of this gift always known to be fit. Donors, the true heroes in this feat. Excess iron given off and their livers revitalized. Immune system improved with risk of cancer reduced. Possibilities of heart attacks lowered and new blood cells produced. A gift when given that blesses the giver's life. Wouldn't you rather be one? Donate today, save a life, and that life might just be yours.
Orúkọ mi ni Abdulgani Adéyẹmí Dòsùnmọ̀, mo wá láti ìpínlẹ̀ Èkó. Tí bá máa rántí on the 10th January 2011, ìjọ yẹn ìyàwó ẹ̀gbọ́n mi fẹ́ bímọ, wọ́n dẹ̀ fẹ́ ṣe operation fún. Wọ́n fẹ́ ṣe operation fún, tí wọ́n wá lọ nídìí láti gba ìjọ yẹn padà. Ní inú ibi báyìí, ẹ̀mẹ́rin. Àǹfààní tó dá wà ń bẹ, ó ń jẹ́ kára jí pépé, kò ní sí àìsàn kankan lára, èèyàn máa wà alright. Ó máa bẹ̀rù àǹfààní tó dá wà ń bẹ because lẹ́nu ọjọ́ mẹ́ta yìí náà tíyàwó tèmi náà fẹ́ bímọ, mo jàǹfààní pé mò ń fi ẹ̀jẹ̀ sílẹ̀ déédéé, tínú mi dẹ̀ dùn sí tó dẹ̀ fún mi ní ìwúrí àti tí máa ṣe sí tí máa fi dàgbà. ẹ̀jẹ̀ fífílẹ̀ dá o ẹ lọ́ máa fẹ̀jẹ̀ lẹ̀ o ó ṣara láǹfààní kẹ́dẹ̀ fi máa ṣèbù ẹ̀mí o.
I donate blood to save life. I've been donating blood since 2010, and right now I donate 4 times in a year. I donate blood to save life, and aside the fact that you are saving lives, it also reduces the risk of having liver and heart diseases. It also reduces the risk of having cancer disease, and it helps develop new blood cells and so many others. I donated blood because I was invited by a friend then. He actually told me that donating blood saved lives, so I said, okay, let's go together. So that was actually my first reason of donating blood then. They don't need to be scared because each time you donate blood, aside the fact that you are doing yourself good, you're also saving other people's lives. Give blood to save lives.
Blood is donated from the donor clinics of hospitals. In Lagos State, we've got 28 public donor centers, which is resided in the general hospitals, as well as the Lagos State Blood Transfusion Service donor centers. When blood is donated, the blood is taken to any of the 8 screening centers in Lagos State. The blood is screened using a 4th generation ELISA technology to be sure that the blood is free of infectious agents like HIV 1 and 2, hepatitis B, hepatitis C, as well as syphilis. Once it is screened and deemed fit for transfusion, the Lagos State logo is attached to the blood to show and to certify that the blood has been duly screened through quality assured measures. Following the screening process, all the blood is stored at the blood bank waiting for the request for it to be cross-matched for transfusion. Once there is a need for blood from any of the hospitals, the request is taken to the blood bank with a well-filled form as well as blood in a plain bottle for the appropriate cross-matching processes. Blood isn't just given like that. Every unit of blood collected at the Lagos State Blood Transfusion Service is appropriately processed into blood components, because we want you to know that each unit of blood can save 3 lives.
At times, we have different blood products and blood being requested from each hospital. We can request for whole blood, packed cell. If it is whole blood, this is how the blood it looks like. And any blood in Lagos State without this logo, you cannot issue it. And in case the doctor requested for fresh frozen plasma, which is another product, his own logo is different from the logo of the blood. Now, after that, then you proceed on the cross-matching. In the request form, the doctor can indicate if it's an emergency or full cross-match. The emergency takes 15 minutes, while the full cross-match takes 1 hour. And in Lagos State Blood Transfusion Service, all donor, of course, we do more of voluntary blood donor. All units of blood collected from our voluntary donors, our team, right? We are all genotypes. That's why it's running the genotype of the blood now. And the patient from each hospital also request for genotype to serve blood because of sickle cell patients or some patients who have hematological disorder. Then after the cross-matching with the normal process, we do at room temperature, you incubate at 37 degrees centigrade. After the completion of that, then you proceed to the record section.
So each unit that you donate can save 3 lives. And that's why we appeal to you that you be a lifesaver.
Donate blood, give blood,
save lives. Save lives.
Continue to give blood, save lives.
We're going to start